At this time, would like to introduce Lauren House, who can tell you a little bit more about what she does and what she's going to be speaking about today. Thank you so much, Lauren.
Thank you. Appreciate the invitation to join you all this morning. My name is Lauren House. I'm the Bureau Director for Community Services with the Office of Developmental Programs. And I often say when I do my introduction that, my title doesn't really tell folks what I do in the course of a day. And so really what we're doing in community services is operations, right? And so we are overseeing all of the waiver implementation across the state. We work closely with our county partners, our administrative entities. We have oversight of all of our supports coordination organizations across the state. And then we're also doing basically monitoring of providers, right? So through both licensing of licensed programs, and then also when it comes to our quality assessment and improvement process, our Bureau is responsible for all of those activities. But really, the important piece of what we're doing is making sure that Pennsylvanians who need services through our program are getting them, and that those services are of high quality, and that they are helping folks live the lives that they want to live. So I'll stop there after my intro and move on to our other presenters who were so kind to join me today. So Julie, do you want to do a quick intro?
Sure. Hi, my name is Julie Moshan. I'm the Director for the Division of Policy and Innovation. So we are a support division, which means we work closely with Lauren's division, and we have, a kind of a financial division and all the divisions. So, right, to create rules and requirements to meet people's needs. So public feedback in forums such as this is extremely helpful in developing policies to meet the needs of the people that we serve and their families. And we also are responsible for ensuring we comply with federal requirements. So there are lots of federal requirements, and so we have to balance all of those.
Hi, I'm Joe Hart. I'm a nursing administrator with the Office of Developmental Programs. I'm currently the lead for state health initiatives, which is what I'm here to talk about today is one of our new initiatives called STAT. So I'm a registered nurse.
All right. Thanks, Julie and Jill. So let me pull my screen up so that folks see what I'm seeing. And we got a lot to cover today. And so please feel free to drop questions in the Q&A pane. We will kind of stop after each section. I will cover a couple of topics and have an opportunity to answer questions around those specific topics. And then same thing after Julie's portion, and then after Joe's portion, we'll have an opportunity for more questions. So please use the question and answer pane liberally. So want to just give an overview of the agenda, things that we're going to cover this morning. I'll go over performance-based contracting and our program growth strategy. And then Julie's going to cover some of the latest and greatest changes by way of different services, and maybe changes to services over the last, not only the most recent waiver amendment, but a couple of our more recent ones, maybe 2 or 3 back, just to give folks a refresher, or maybe a first time opportunity to hear about some of these great changes. And then we'll have Joe talk about the Specialty Telehealth and Assessment Team, or STAT, which we are also super excited about. So first, before we kind of get started talking about performance-based contracting, a way that we always like to start not only external meetings, but we do this internally as well, is to really ground ourselves in our mission, vision, and values. So when we hear everyday lives, we know what that means, right? Because we sort of work within the programs. But the thing about everyday lives that I think is super powerful is that when you're talking to someone who isn't particularly familiar with our programs and what we do, and maybe they don't have a loved one that they're supporting, When we use our mission statement, it's almost like a light bulb moment for them, right? It really is sometimes pretty complicated to explain the work that we do. But when you use the phrase everyday lives, people, kind of more quickly get that and get, what we're talking about and what we're driving at. And, all credit goes to Deputy Secretary Kristen Ahrens, because she's pointed out in a number of different settings that not many organizations or businesses can sum up basically the whole of their values in just 2 words. And so for that, I think I am certainly grateful to be able to have, right, something like everyday lives that is so powerful and that so concisely and simply summarizes what we're all about and what's important to us. And, we have up on the screen, this is a graphic that folks may have seen over the last, couple of years at this point. But these are really, some of our core values here. And the thing that, jumps out to me when we look at this graphic is that these values of choice and control and health and wellness and safety, these are not things that are exclusive to people with disabilities, right? These are things that all of us want in our lives. And the thing about not only our mission statement, being simple and straight to the point, but also, our values is another really critical connection point with others in the community who maybe, don't do the same work that we do or have, someone that they love and care about in their lives with a disability. But it's a critical connection point for folks to understand that we honestly have more in common with other people, right, than we think who are different, right? And so knowing that we can lean on these, kind of straight to the point value statements to help others around us recognize that we're all, pretty much the same, pretty much driving at the same thing, in terms of having a good life. So in the context of our mission and our vision and our values, when we first set out to address some of the most serious issues that we were seeing within the ODP service system, and some of those being, health and safety concerns for folks receiving services, people experiencing really terrible, bad outcomes, as while receiving services. This, starting with our mission and our vision and our values is where we started. We always start with this, like I said, and then we will check ourselves along the way to make sure that we're not, drifting away from the mission and the vision. So as we talk about the upcoming changes related to performance-based contracting, something that I want to point out is that you will see these value statements embedded in the work and embedded in, down to some of the actual performance measures that we have set forth for residential providers and will in the future for supports coordination organizations. You will see these value statements reflected directly in the performance standards and the performance measures. So this is, I think, a great visual. This is pulled directly from our implementation guide on performance-based contracting. If folks haven't had an opportunity to review that document yet, it is a massive resource. It's a couple hundred pages long, but it really does do a great job of sort of laying the foundation for, why we're moving in this direction. And then also it was intended to be kind of a one-stop shop for residential providers as they are, working towards the implementation of performance-based contracting. So it is a little heavy, it's pretty dense, but it is a nice resource that's out there and available. One thing I will also just let people know is that we have kind of a more condensed version, what we like to call sometimes like the quick hits. What do people need to know? That is geared towards individuals and families. And so that is currently in production. We're aiming to have that done, I think, honestly, by the end of this week. And so folks should be able to see that in the next couple of weeks or so once we're ready to publish that. So this, again, really is a kind of a visual description of how we got to the residential provider standards that we're using for this first go round. So as you all know, our Everyday Lives document is, it was written, by people with lived experience. And it is everything that is behind driving ODP policy. And the other great thing about Everyday Lives is, we promote, right, folks having, great lives in the community. And we use that experience, right, to continue to evolve and update and change based on, what stakeholders are telling us, right? Like Julie said in her introduction, the most critical piece of us doing any of this work is getting stakeholder feedback so that all of that can be incorporated into how anything changes in the future. So we looked to evaluate our future innovation. We have an Isaac recommendation exclusively built on exploring innovation and that sort of thing. And so again, this is grounded in our Isaac recommendations and our Everyday Lives values. And again, you see reflected here, this is an opportunity for all of ODP's stakeholders to help inform the policy change. So we kind of came to, as we talked about what are all the possibilities with respect to how we can change our programs to better be able to meet the needs of people that we're supporting. Where we landed on is what we're calling in Pennsylvania performance-based contracting. But if you look at CMS documents, the actual 1915 B4 waiver, this is actually called selective contracting. So if you've been following this from the very beginning, you will have kind of heard that term selective contracting that eventually evolved into what we're calling performance-based contracting, because that's exactly, it's a great way of describing what it is that we're driving at, right? We're driving at better outcomes for people and, provider performance being incentivized to make sure that people are achieving those, good quality, or they're getting those good quality services, and that they're achieving their goals and their outcomes. And really that's what's behind all of this, that we've got good high quality services, that we've got a workforce that is competent and well trained and is able to do the work that is in front of them. And then that we also have a strong system going forward to be able to meet the needs of all of the people who need services in Pennsylvania. So within performance-based contracting, what you will see, and we'll talk a little bit more about this later as well, but this approach is basically putting residential providers into different tiers. And so we have 4 tiers. The first tier is conditional, and a conditional tier essentially means that we've got a residential provider who is struggling to meet basic compliance with licensing. And so these are going to be providers who are on a provisional license, or providers who have had their license revoked. And then we have primary tier. Primary tier was named primary for the reason that it really is going to be our primary workforce, our primary group of providers who are qualified to do this work. And so there is nothing bad at all about being in primary tier. Primary is essentially, right, providers who are in good standing today and are continue to be in good standing into the future. They're moving forward with being in that primary tier. Our select residential is going to be providers who offer expanded service offerings by way of residential services. So these providers offer at least 2 of 3 of our different residential options, meaning that they offer residential habilitation and life sharing, or residential habilitation and supported living, or maybe they just offer supported living, and life sharing. So any combination of those three, what we consider our residential services, are kind of the basic criteria for our select residential providers. And then last, we have clinically enhanced residential providers, who are providers who meet a set of criteria that we've established, where they are able to provide a higher intensity clinical service. So think about folks who have really intense and complicated medical needs, or folks who have challenging behavioral needs, where they need, specialty trained staff. They need certain maybe staffing ratios to maintain their health and safety. And so that's the provider pool that we're looking for in clinically enhanced residential. And in order to meet those tiers, this is where the residential provider standards come into play, that we have these measures that will kind of evaluate or measure providers and their ability to bring on, staff in their workforce and train those staff, ways in which they're using technology to be able to support people to live either more independently. And maybe living independently is, kind of a future goal, but even if it's evaluating, how do we start to take some of those smaller steps towards doing some, discrete tasks independently, right? We always talk about sort of this future state of folks being able to live more independently, and need to focus on how do we build those sort of steps, those building blocks to help them get there. We want to reinforce and promote the use of technology to do those things as well. Also, have measures that are built around promoting independence and competitive integrated employment and community integration. Certainly, we are measuring providers' ability to support people who have complex needs, like I talked about. And then lastly, providers' ability to use data to be able to improve the quality of their services. So I referenced our Everyday Lives recommendation number 13, which is evaluate future innovation based on our Everyday Lives principles. And so we recognize that healthy service delivery, right, meaning having providers who are all across the Commonwealth, providers who have different areas of expertise, providers who offer a multitude of residential services, right, providers who vary in size. All of that is absolutely necessary in order for us to have a robust service system. And so going into, developing the standards and measures for residential providers to meet, all of these things, and honestly, many more, additional sort of variables and factors had to be considered as we develop the standards, because we know that there are going to be some providers who have certain advantages, right? Sometimes it's a size advantage, sometimes it's a location advantage. So all of those things had to be taken into consideration as we sat down to develop these measures. And then one of the other things, right, that we really leaned into, because we know that this is critical. It's something we hear every time, that we meet with individuals and families, with provider agencies. The concern is around, staffing support, right? And so it's, we're finding, right, the workforce that is qualified to do this work, training the workforce to do a good job when they are on shift. And then how do we retain those staff, right? Those staff who want to make a career out of being a direct support professional. How do we, elevate the title of direct support professional? Because we know that direct support professionals are so much more than, what I think sort of the immediate response of sort of caregiving is, right? We're asking DSPs, yes, to do, of course, some caretaking, work in the course of their day, but they're also, community integration experts. They're also, constantly assessing and evaluating environments to mitigate risk and getting people employed in many cases, right? Teaching people skills so that they maybe can, get a job in the future. They're doing so much more than, really they're recognized for. And so how do we, continue to professionalize and elevate the direct support professional as, a career, right? So you will see a lot of the strategies embedded in the measures really do drive at professionalizing the workforce and then retaining that workforce. And then long term, we had, a lot of sort of goals to meet when it comes to what our long term objectives are. So first of which is system sustainability. And we, already talked about the professional skilled workforce. We need to attract those folks, and then we need to keep those folks once we've made the investments in getting them the training and the skills that they need. We need to look towards life force and utilize life force. Really not, this is not just like a one-time thing, right? That we are using that life force tool, those life force tools. We really need to use those tools and embed them in our practice in an ongoing way. Because when people, meet their goals, we don't want to just say, well, you've met your goal and that's wonderful and that's fine. We all, throughout our lifespan, right, have continued opportunities to say, maybe I want to change my career. Maybe I want to learn a new, hobby. We have those opportunities to, kind of create those plans for ourselves, and we need to continue to embed that in our regular planning. Just a quick preview, which we don't actually have on the agenda today, is enterprise case management, which will be our HCSIS replacement. You will see once that is launched later in 2025, I believe is the anticipated launch date, but Life Force is going to be embedded in the planning process from the beginning. So a lot of our ISP and monitoring tools for supports coordination will take on a lot of the what people know and like about Life Force. And then lastly, we are committed to ending the waiting list. And we're going to talk a little bit more about growth strategy in a couple of minutes. But really, this has been such an incredible time to be working in state government, working to support people with disabilities, because we have really never had the strength and backing like we have today when it comes to the governor, when it comes to the secretary, and then Deputy Secretary Aarons. These folks are committed and have a plan to eliminate the waiting list. So also moving towards a value-based payment structure, right? So where right now providers get paid regardless of the quality of the service that was delivered, right? And so they get paid, today for the service that they delivered yesterday. And again, whether that was good or bad, whether someone achieved their goal or not, they're getting paid. And so balancing that with how do we incentivize providers to support people to meet those goals, right? We want to start to work in that value-based payment structure with performance-based contracting. Also, we need to integrate and coordinate all of our services. And this isn't just ODP services. This isn't just, residential provider integrating and coordinating with the community participation support provider or the employment support provider. But this is, behavioral health services. This is medical services. It's critical, right? When you're talking about supporting a person, we in ODP have long said we're not just supporting a person relative to their disability, right? We're supporting them relative to all of the other sort of areas that they might need support in. And so how do we do a better job of integrating those services within, what we have within ODP, or, coordinating those services and making sure that, all of those different providers, whether it's the outpatient mental health provider, making sure that there is a link between the residential provider and that mental health provider to know what's going on, with that person and how to best support that person. So we're really laying the foundation of all of this now, right? We know that the first couple of years, honestly, we are going to need to sort of take it slow, right? And move slowly with this, because this is, major systems change. But all of that, right, those are our future and long-term goals. And so that's exactly what we're doing now, right, is sort of laying the groundwork. And lastly, the priority here is that we elevate the quality of all providers, right? So that we don't just say, providers who are already meeting these metrics, great, they're getting clinically, they're making clinically enhanced tier, or they're, making select tier. We need to elevate the quality of all providers, because we need all of the providers, right, to be able to support people who are, presenting to our front door who need the services, right? And the other thing to say about lifting the quality of all providers is the way that we're structuring some of our financial tools, things like pay for performance measures. They're going to be sort of structured in a way that is, more equitable, because we know that some providers, right, are going to be starting at kind of a different place than others, right? Our larger providers, maybe they do have resources and they have already started, let's say, for example, down the path of direct support professional credentialing. And so they're already at a different starting place than providers who potentially are smaller, or who are newer, or who operate in a more remote or rural area. And so we need to sort of level that playing field and make sure that it's not just, the provider who already is started down the path on DSP credentialing, they're getting paid for performance. And, the other providers, they haven't started this, so they don't get anything. It has to sort of be relative to where these providers are starting. So I wanted to talk a little bit about, when we sat down initially and we're brainstorming about, what are the issues within residential services specifically that we're having trouble with, right? And so it really came down to what you see in the sort of 4 quadrants of the circle. So struggling with sustainability, right? Like we talked about, struggling definitely with workforce, struggling with clinical capacity, so making sure that providers have the sort of clinical teams and training that they need to be able to support people with more complex needs, and then access to services, right? This was another really, really hot topic when we sat down to brainstorm on how do we try to make these things better. We often, right, we're waiting for residential providers. They would say, sure, we're interested in supporting this person, but it's going to take us 9 months, 12 months to establish a program for them. Meanwhile, they're waiting in hospital, emergency departments in some cases, inpatient units in hospitals, other, mental health programs that they were, ready for disposition and discharge, but we didn't have, residential services ready, right, in the community for them. And so within those quadrants, you'll see where we have specific performance standards and performance measures to be able to drive, right, at some of these issues. And so, relative to sustainability, some of the measures that you'll see, if you take a look at either the implementation guide or really any of the resources that we have on the performance-based contracting page of MyODP, you'll see again where these measures really drive at the different quadrants, right? So sustainability, we need to be able to offer more than just residential habilitation. We need more providers who are offering life sharing. We need more providers who are offering supported living. And so you'll see that reflected in the measures. Employment is also huge relative to sustainability of the system. We want people to, be competitively employed in their communities. People want to be employed in their communities. It's more than just, what the system wants. It really is about when you ask people, what they want to do, employment rises to the top of the list. So you'll see employment reflected in those measures. And then, of course, family engagement, right? Families, individuals and families need to be satisfied with services, and their families need to be engaged, not only right at the planning process, but all along, right, through that person being supported. And so knowing that family engagement is critical to the long-term success of performance-based contracting, of any system change that we're undertaking. It is critical. On the workforce side, we talked about a little bit about DSP credentialing. Again, that's one of the ways that we're looking to professionalize the workforce, right? And making sure that folks, that staff, right, are having the types of training that they need to provide great service to individuals that they're supporting. But also credentialing creates opportunities for staff related to, right, like once they're credentialed, It's something they can take with them, right? And so if they're working for provider A and they're credentialed and maybe they move and that provider doesn't have employment opportunities for them, and they go to provider B, they're recognized at that agency as this is a well-qualified staff, right? This person is already credentialed. And so, gives them an opportunity to not only move between provider agencies, but also, gives them the opportunity for advancement, right, within their career. So, credentialing, we're placing a lot of emphasis on DSP, not only DSP credentialing, but also frontline supervisor credentialing as well, because having a good supervisor is a lot of what keeps many of us in our jobs, and so we are also emphasizing frontline supervisor credentialing as well. Utilizing technology is another area relative to how can we maybe offload, right, some of the work for the DSP, right? If there is technology that is available and could be used to support someone to do that activity more independently, maybe in the future live more independently, or are there technology solutions that just simply keep a person healthier or safer? That's another way, right, that technology can sort of relieve some of maybe that like mental load from the DSP. Just to know that they have, right, an electronic, reliable method to track weights, blood sugars. Like, we have all of these different things that can help support the DSPs to feel confident and competent in their roles. And then lastly, in terms of workforce, we know and we hear often, right, that the DSP wages is a concern. And so we need to pay people more, right, like what they're worth. And so with the clinically enhanced tier and with the select tier, there will be rate add-ons for those providers. And additionally, there will be a couple pay for performance measures that will support higher DSP wages, better training, and that sort of thing. So moving down to the quadrant around clinical capacity, right now we are kind of seeing the acuity of the support needs of individuals has really been increasing over time, and that's not expected to change. We're going to continue to see needs increase. And so residential providers are going to need to have clinical teams available to be able to provide the right kind of supports to folks and be able to provide therapeutic and restorative environments for folks who are in need of those. And so between having those highly qualified clinical teams, and then also making sure that there's training and resource available on trauma-informed care and crisis intervention training, is another approach in terms of supporting those providers to be able to provide high quality services to folks with more complex needs. And so making sure that that training is comprehensive, that it is trauma informed for anybody who does require crisis intervention, and then also making sure that anybody who is currently using a restrictive procedure and needs a restrictive procedure in place to keep them healthy and safe, that there is frequent review of that, and that the clinical teams are informing really the ongoing need for any of those restrictive procedures. And then lastly, around access, what you'll see in the measures are referral and discharge standards. And so what we're really looking to do here is change the referral and discharge process to improve access to residential services. Right now, we really don't know, when providers are getting referrals for to support people in residential services. And what we sometimes hear is supports coordinators will send referrals and not hear anything back. And so we're looking to ensure that there's tracking on both ends, making sure that there's follow-up, right, in response to those referrals. And then the other thing that we're looking to do specifically for select and clinically enhanced providers is build in some expectations around referrals being accepted and how quickly people can actually get into services. And so establishing some timeframes for residential providers to meet. So or if the provider says, yes, we can support this person, the goal would be that for someone in residential habilitation, they would move within 90 days to that residential provider. And then for supported living or life sharing, knowing that sometimes like the matching process for life sharing can take a little time, or locating appropriate housing for someone for supported living can take some additional time. That time frame is set at I think it's 180 days. But right now we don't have any of those standards, right? And so we're kind of slowly putting these expectations in place for goals for providers to meet over time. And so just a quick review to make sure that folks know exactly what services will be impacted for 2025, January 2025. All of our residential services will roll into performance-based contracting. So that will be residential habilitation, life sharing, and supported living. And then in 2026, we will roll supports coordination into performance-based contracting. We have gotten a lot of questions about whether or not other service types will eventually roll into performance-based contracting. At this point, we don't really have any plans on the table, but again, another opportunity for where you're seeing the need to really elevate the quality of the services that are being delivered. We're always happy to take that feedback and kind of hear about ways that we can improve those services as well. So just a quick sort of brief history and where we're going next with performance-based contracting. So way back, feels like a million years ago, June of 2023, we published a concept paper and got stakeholder input on that concept paper. We incorporated the feedback, from what folks provided on the concept paper. And at that same time, we convened the residential strategic thinking work group to develop our performance measures that exist today. And so the residential strategic thinking work group was a group of probably 30 to 35 folks, primarily residential providers from all across the Commonwealth, providers of different sizes. And we had a couple of administrative entity staff, a couple of supports coordination staff, and a few ODP staff that joined that group to develop the initial draft of the performance standards and measures. In April of 2024, we published the proposed performance standards and our waiver applications and held our public comment period. Hopefully many of you had an opportunity to join at least one of those and provide public comment. And then following that, we did make changes. We had a lot of changes based on public comment, and during that time period held some provider preparedness summits to make sure that providers were getting their questions answered relative to how they would meet the proposed performance standards. In July, we submitted our waiver applications and published our final performance measures and then the implementation guide that I've talked about a couple times. In August, that was when our first provider submission period opened. We had 36 providers submit in August. Providers were not required to submit in August. We are going to have 2 review periods. So we had August, which of course has closed now. but we will also have a second round of provider submissions in February and March of 2025. So right now, our scoring team is working on scoring all of the submissions that were provided in August. In November, providers are going to receive notification of their tier determination, and if they met the standards for primary, select, or clinically enhanced. And then January 2025 officially is when performance-based contracting will begin. And like I said, in February, March, we will have another opportunity for the remainder of residential providers to submit, and everyone will have to submit during that period. So anybody who didn't submit in August, they will have to submit in February or March. And we reviewed a little bit of this already, but just to make sure that folks are kind of clear on what the expectations are for residential providers in terms of meeting the tiers. We've got conditional. Again, this is only providers who are operating under a provisional or revoked license, meaning, right, they've got some struggles meeting the basic licensing compliance measures. Primary, that's, again, our primary pool of providers. They meet all of our current waiver standards. And we did cook in a couple additional measures for primary providers to meet as well. Again, this is about, lifting the quality of all of our residential providers. Select, again, is for folks who are offering at least 2 of the 3 residential services, and they've got a couple additional standards to meet. And then clinically enhanced, again, is for providers that are offering really high level clinically enhanced behavioral or medical support needs, supports to meet the needs of those folks who need them. So I know I just said a lot about performance-based contracting. I am going to take a minute and see if we have questions on anything that was covered so far.
No questions yet, Lauren.
All right.
So we'll keep watching, and if anything comes up, that was a lot of great information. We'll certainly let you know.
All right, great. Well, we'll keep moving. We're going to shift into our multi-year program growth strategy next. So hopefully folks have been following this really, really exciting initiative over the last less than a year or so. But it really has been full speed ahead on the program growth strategy. So back in February of this year, the Shapiro administration announced our multi-year program growth strategy. And like I talked about a little bit earlier, we are looking to end the emergency waiting list for adults in Pennsylvania, which really is, I think, more than a statement, right, on our values and on the governor's values and on the secretary's values. As former county commissioners, both of them, they often, right, were hearing the struggles of individuals and families who were waiting for services because they didn't have funding available to them. And so both of them, came into their roles committed to how do we make this better for people, right? How do we help people be able to plan for the future and not sort of have this stress looming over them by not being able to look for residential providers or look for service providers or even just get some help in the family home, right? Making sure that folks had an opportunity to be part of their community. If, the parents were working or, siblings were working and unable to, provide that kind of support to folks. So they really did come into this committed and with a clear vision, and really is remarkable the steps that they're taking to support the elimination of the waiting list. So program expansion is going to be accomplished really in 2 ways, right? So we do have to add waiver capacity. So to both our community living and consolidated waivers, the next slide we'll talk about numbers But part of this really is, truly growing the number of waivers that we have available to us today. The second piece of this, though, is changing the way that we're managing waiver capacity so that we can support more people in the community. And the way in which we are going to be able to get at this is changing the way that counties manage their waiver capacity numbers. So right now, as it stands today, counties have a finite number of waiver capacity that is available to them. And when they hit that number, so let's hypothetically say a county has 100 consolidated waivers available to them. So when they hit 100, they can't continue to enroll people, after they have 100 people enrolled in consolidated waiver. The reality is, though, that every year counties all across the Commonwealth will have they all have a max budget, in terms of spend. But we've never really managed budget in this way, and never really had counties, not since I think it was 2008, managing actual waiver budgets in this way, They've always been responsible for authorizing the services, but since payment through Treasury many years ago, they sort of lost the responsibility of staying under budget effectively. So we want to move back to not necessarily counties actually having and paying, claims and that sort of thing, but giving them sort of their maximum number, not only in terms of waiver spots, but also budget. So let's go back to the example of a county who has 100 consolidated waiver spots available to them. They're also going to be able to see what their max spend is. And so let's say that county's max spend is $5 million. So of the 100 people that are enrolled in consolidated waiver, over the last couple of years, the county can see, well, we're only spending $2.5 million to support these 100 people. And if our max budget is really $5 million, we think that we would be able to add 2 additional consolidated waivers and 3 additional community living waivers, So by using historical data, where counties can see the trend in terms of how much people are spending on an annual basis to receive services that they need, counties will be able to request additional waiver capacity from ODP on a quarterly basis and say, the last couple of years of data are showing us that we are underspending, and our forecasting tools are telling us that we would be able to absorb another 2 consolidated capacity, another 3 community living capacity. And we will be able to then allocate additional capacity to those counties to be able to pull people off of that emergency waiting list who are waiting for services, So this really is a fairly drastic shift in terms of the way that we've been managing waiver capacity for a long time. And so this is truly very exciting to have this opportunity to change the way that counties are going to be able to manage waiver capacity and manage their budgets. So I talked a little bit about adding waiver capacity, which we did do and continue to do through governor's enacted budget. So in February of 2024, we were able to release 1,250 community living waivers and 400 consolidated waivers. And again, if you've been, working in ODP programs or in human services for a long time, these numbers are huge. These numbers we haven't seen numbers like this in, maybe in this way ever, and so those capacity have been released to the field. The enacted state budget for this year provided for another 1,250 community living waivers and another 250 consolidated waivers. And so right now, what we're doing is we are actively releasing. Counties got their allocation letters, I believe, sometime last week. So they're going to release half of that capacity now of both community living and consolidated. And then in January, they will be able to enroll the remainder of those folks in community living or consolidated waiver. So just to give kind of an example of why increasing waiver capacity has an impact on our ability to support more people. Just kind of an example here on the screen. So as we have more waiver capacity, the opportunities for new people to get enrolled in waiver through turnover also increases. So very consistently, and we've actually proven this theory. So not only is our data very stable in terms of year over year turnover, it's been at 4% for a decade or more. So 4% of waivers become vacant every year. And again, we have proven our theory with the way that we manage person-family capacity now. So you'll see in all of these numbers, right, and all of these additional waiver capacity releases, we're not getting additional person-family capacity because we're managing person-family capacity not through the addition of new waiver slots, but through turnover, right, just through natural turnover over the course of a year. And so we're able to support to at least offer PFDS enrollment to all of our high school grads. And the counties have been able to do that successfully for the last probably 5 or 6 years or so at this point without being provided any additional person-family capacity. But you'll see that the example here is when we've got 4% turnover every year, if we have 40,000 people enrolled in our waiver programs, that's 1,600 new people that could be enrolled through turnover, right? And turnover, the way that turnover is sort of characterized, or the definition is people, leaving, vacating those waiver slots. So it is unfortunately due to death. Sometimes it's people who move out of state because they can't take their waiver with them if they move out of state. It's people voluntarily disenrolling from services, and then it's also the turnover from folks who there's a change in need, and they maybe person family doesn't meet their need any longer, and so they need community living or consolidated waiver. But so again, that's just sort of an example of how that turnover drives the way in which we can get people removed from the emergency waiting list. And so I will stop there. And that is actually my last slide. So again, if folks have questions, I'm more than happy to answer them. But if not, we can move on to Julie's portion.
Lauren, there are 2 questions.
Yeah.
This is Maria Smith. And the first one is not a residential question, but there's been a discussion or plans of having a cap on sports coordination caseloads. Or are caseload numbers taken into account when determining SEO status?
Oh, so this is interesting and great question. So we have not necessarily talked about a cap on SE caseload, but what I will share is as we move into performance-based contracting for supports coordination, something that we're really interested in doing is moving away from supports coordination billing in a 15-minute unit increment. We know that it's a huge stressor for supports coordinators thinking about life, in 15-minute units. And oftentimes, there's just, we're not driving at really what we want, right, by using the 15-minute unit. And so we really want to move to an alternative way of paying supports coordination. So that could look like a case rate, like a monthly rate per member. But one of the things that we're looking at and trying to we're studying it right now is there sort of something that are there indicators that tell us that someone needs intensive case management or intensive supports coordination? And that could be a thing that then supports coordination organizations say, if you're an SC that's going to carry an intensive caseload, maybe their caseload is a little bit lighter than an SC who is not supporting an intensive caseload. So those are all sort of ideas that we're working on studying and evaluating what those impacts might be. But it's a great question. Short answer is no, we're not at a place where we're limiting caseload size now, but it's something that we will have to address, in the future with performance-based contracting and supports coordination.
And there's one other question. Julie says, I understand the idea of potential addition of supporting more waivers using budget. My concern is that we have a community living waiver for my son and would happily spend more if the services were available. How will this be monitored?
Sure. So I think what I'm getting from the question is if you're struggling to find service providers or providers who have staff to be able to provide the services, and definitely understand, and we hear that often, from individuals and families and provider agencies about the struggles to find staff to be able to render those services. And so we know that in moving to the program growth strategy and the elimination of the adult waiting list, we will need to change our current PUNS process, like our prioritization of urgency of need, to capture some additional information, because what we're hearing is, and even from my own experience working for two administrative entities in the Southeast, PUNS wasn't really giving us exactly what we needed to be able to make the determinations on who was getting next waiver capacity. So we always had to ask supports coordination for additional information. So we are looking at changing PUNS to better capture sort of what those specific circumstances are relative to that person. And what we need to do is shift away from using PUNS as the way to, like, PUNS in its purest form should be how do we know how many people are waiting for funding, right? And then secondarily, we need to know how many people maybe have funding but are waiting for those services to start. And so that's going to be the distinction. One of the distinctions in the new PUNS process will be PUNS is for funding. And then there will be it's not named yet, so open to suggestions. Are there people who have that funding and they're still looking for services to be fulfilled, so that we can, kind of drive at how many people are still, kind of in that category of waiting for services to start. And then just on the question around budget, that utilization, right, is another thing similar to those trends with turnover. Utilization almost always runs around 80 to 90% under authorization, right? And so what that means is we have more money encumbered than is actually needed for folks to receive services. And this, the data, there's a little bit, kind of fluctuation in the data because of COVID and the years that services were, so dramatically disrupted. But even prior to that, we have years of, more stable data that again tell us the between 80 and 90% really is sort of at the right threshold. And so what really we'll be looking for is, we're not looking for services to be reduced, right? We're not looking for people to have services, taken away. It's at the end of the year. Basically, it's how can, like, the county close the gap between what was utilized and what was authorized. And that doesn't mean that necessarily has to carry over, right, in years going forward, because maybe you can't think about the sort of larger budget like, you have to think about it in the larger context, right? There will always be somebody who maybe misses days of service for whatever reason, right? And so that's where those, like, historical trends come into play, to make sure that counties, right, actually will have that budget capacity going forward into the future, and not necessarily on that sort of individual basis. Like, some of the questions we'll get is like, well, if my loved one misses, 30 days of residential this year because they were, unfortunately hospitalized, or we went on a long family vacation, or what have you, that isn't going to happen again next year. for that person, but it will probably happen, right? Data tells us that it will happen for others, right? And so that's kind of the way we have to think about counties being able to manage to budget. Hopefully that helps.
Okay, there are two other questions. The first one is the person and family directed services waiver is no longer covering the costs of the services it once did. Examples are CPS program and transportation. Therefore, more grads need the community living waivers. Has this been considered with regard to the amount of the community living waivers available?
Yeah, that's a great question. And one of the things, right, that we will likely see through the program growth strategy, right, is the ability for counties to sort of create what they need, right, from their existing capacity, right, and what people are not necessarily using. So if you remember a couple of years back, ODP offered for counties when community living waiver was first introduced. There was sort of this opportunity for like a trade-in. You could trade 2 PFDS for 1 community living waiver, right? And so we're not engaging in the trading anymore, but based on spend, right, and based on if community living waiver is what counties need, then absolutely, right, they will be able to on a quarterly basis let their waiver capacity manager know in the region, we need more of this capacity, and because we're underspending on our PFDS budget, we will be able to grant them the additional community living waivers that people need. Good question.
And then the last question is, she's saying this excellent presentation leaves me with so many questions and thoughts and questions. I'm taking a lot of notes. Is it possible for us to submit thoughtful comments in the next few days? As a parent, I'm very excited about the future. Thank you. Also, will we have access to a recording of this session, which I think we've said yes, but go ahead. Yes.
Yeah, absolutely. Cheryl, you're more than welcome to send any comments or questions that you have over to myself. I'll be glad to answer them. And we're excited too, really. We're excited about the opportunities that both performance-based contracting and program growth are going to provide individuals that we're supporting to live happier, safer, healthier lives overall. For us to be able to, work towards ending the waiting list. These are all of these things, right? Are goals that we set out with very early on, and to be right at a place where we are working towards value-based payment, paying for outcomes for residential providers, is amazing that we're working towards that and we're laying the groundwork there. And similarly, and in the waiting list is, I think anybody who's worked in the system for any amount of time, it's been a dream.
Okay, we have 2 more questions.
Sure.
One is, would it be possible to encourage community day programs that don't accept clients needing one-on-one support to allow individuals to attend with their own SSP support on an as-needed basis? Some day programs already do this, but my son needs more options.
Sure. This is a great question. And I would encourage, Carol, I would encourage you to reach out to your supports coordinator and ask them to get some input from the county to support this. So there's going to be some difficulty there, right? So like having a support staff, right, with an individual that they're working, but they're not working for that day program, right? And that day program who is an employer, who is a licensed entity, who's responsible for anything and everything that happens, with regard to that person while they're there and while they're receiving supports from them. It is quite complicated, but we have also heard from providers of CPS programs lately that they want to be able to bring, more people in, that they finally are, locating the staff that they have been looking for to be able to provide those services. And so I would definitely encourage you to outreach to your SC and to the administrative entity for support there. I know that there's some questions still coming in, but just a quick time check. I know Julie has a lot of content to get through, as does Joe. So I don't know, maybe one more question.
Yeah,
Sure.
I think this is the same, says, what is the main difference between CHC waiver and the ODP waiver, especially for a client diagnosed with IDD?
So I think the response to this one, I think, is a little more detailed than maybe I would be able to provide, and certainly on sort of a time crunch. The big difference, right? CHC is a managed care program that is available for Pennsylvanians with eligible diagnoses, right? And so one of the big differences is that there is no waiting list for CHC, right? A person can be determined eligible for that program and be enrolled and have the services and funding available to them to be able to have those services provided. Within ODP, we have a more narrow sort of scope of who is eligible for our services. But we also, of course, right, at the present time, operate a waiting list. And so it is not, an entitlement. It's not something that folks are determined eligible and immediately can begin receiving services. So that's one of the big differences. But I would definitely encourage supports coordination would be a good resource to ask questions on what are the differences between the programs, what are the differences in terms of eligibility requirements. There's lots of resources available for SCs to be able to help answer that question for you.
And there's just a comment and then we'll go on. Kathy says one of the things to reduce emergency waiver would be getting information of availability to parents and guardians sooner while in school through the district. So I think she's making a comment that would be helpful.
Definitely. Yep.
Okay.
All right. Thanks, everybody.
All right, and I just want to make sure, Lauren, it's okay for me to share my screen now. Yes.
Definitely.
Okay.
Yeah.
All right, give me just a second. Get things where I need them. So sorry, my computer is not super. It does not like to have me use a video camera and try to do things at the same time. Okay. All right, so hopefully everyone can see my screen.
Yeah.
Lauren said that you all had some questions about some of our services, and I just want to kind of preface this by saying that any service could be a whole hour presentation in and of itself. So we'll just kind of go over some high level information about the services, and then if you have questions, we can try to answer as many of those as we have time for. So first of all, we are very excited that if approved by the Centers for Medicare and Medicaid Services, the waivers are with CMS right now for review and approval. We will be adding an American Sign Language, or ASL, English Interpreter Service effective January 1st of 2025. So just so everybody has kind of like the basic knowledge, interpreting is the process of conveying English in grammatically correct American Sign Language, and the process of conveying American Sign Language in English. Interpreters maintain the role of a facilitator of communication rather than the focus or initiator of communication. And this comes out of, as Lauren had mentioned, everyday lives recommendations really drive our decisions and our policies. So this comes out of the recommendation to assure effective communication. All right. So some of the questions that people ask about the service is, where can this service be provided? It can be provided in private homes using teleservices, and that's very similar to what we're doing today, where you can see people via video and communicate via electronic devices in real time. And then for limited activities in residential homes, and we say limited activities in residential homes because really our expectation for residential providers is that they have the staff to communicate with the people that they serve on a regular basis. So some of the types of activities are, for residential are like special circumstances like incident investigations or law enforcement activity or another crisis event. When the person needs victims assistance, when you're completing a health risk screening tool. So there's a list of about 7 or 8 different things, activities specific to residential homes because of those expectations. So who can provide this service? Providers and professionals that meet qualification criteria can provide this service through one of the following. So they can enroll, a provider or a professional can enroll with the Office of Developmental Programs. We tend to refer to these as, quote unquote, traditional providers. And then they bill, right? They're the provider that shows up in the individual support plan. They're the one that bills for the service, that kind of thing. They can also do this through an organized healthcare delivery system. And that is where another provider has agreed to kind of check the qualifications for other services, and then they bill that organized healthcare delivery system. So they kind of subcontract with professionals or providers to render the service, and then the organized healthcare delivery system bills for that service. And the organized healthcare delivery system is the one that's in the individual support plan. And then finally, this service can be provided through a participant-directed services model. So that's either the agency with choice or the vendor fiscal employer agent model. So how will this service be paid for? The waivers will pay what the American Sign Language English interpreter provider charges to the general public. So we often refer to this as a vendor payment. And this is what we use for things like home accessibility adaptations. And you'll even hear when we talk about the STAT service later, that's kind of a bit, it's where we have not set a payment yet. We don't have the information that we need to set a payment. And so we will just pay what the general public pays. The cost of the service will not count towards the person, family directed support or community living waiver caps. So they will be exempt from those limits. And interpreter services are limited to an average of 8 hours per day and must be billed using either 15-minute units or 1-hour units. And that was, like I said, just very high level of, hopefully, fingers crossed, service that will be effective January 1st. Now, the benefits counseling service is already approved in the consolidated community living and person family directed support waivers. However, we are looking to make some changes effective January 1st. But to just go back and kind of talk about what benefits counseling is, because it's a very, very important service. It helps individuals understand how employment might impact benefits such as supplemental security income or SSI, housing subsidies, and supplemental nutrition assistance programs. And once again, this is driven by our Everyday Lives recommendation to increase employment. So it's important that people understand that a lot of times they can work, the people in our waivers can work, and still be eligible and not lose eligibility for their waivers. So we have over 8,000 working age people enrolled with the Office of Developmental Programs right now who work, and the vast majority of them still have, they haven't lost their eligibility for medical assistance or things like that. So some of the, so I talked very briefly when I was doing my introduction that there are federal rules about what the waivers can and cannot cover. So benefits counseling is also available through work incentives, planning, and assistance programs, and they're sometimes referred to as WIPAs. And these are this is a federally funded program, and the purpose is to promote employment among those receiving disability benefits. So benefits counseling can only be provided through the waivers when there is kind of a gap in the services provided through the work incentives, planning, and assistance programs. And that's a federal rule. The waivers cannot cover things that are already provided and covered under another program, and especially a federally funded program. So some of the changes that we are with the Centers for Medicare and Medicaid Services for approval, effective January 1st, is we are looking to add activities that can be billed when performed on behalf of an individual. Like the individual does not have to be present, and we call those indirect activities. So prior to January 1st, we said benefits counseling could only be billed when you're doing activities with the individual like present, either via teleservices using technology or like in person. So we got a lot of public comment, a lot of feedback that we should add some of the indirect activities. So we have done that, and those include writing a benefit summary and analysis, reaching out to employers to obtain work incentive information and pay stub information. And so there's a list, once again, about 6 or 7 indirect activities performed on behalf of an individual that benefits counseling can be billed for. And then to kind of accommodate those new activities, we are increasing the limit on the number of hours of benefits counseling from 15 hours a year to 24 hours a year. Okay, and then just staying on benefits counseling, the reason I also talked about the work incentives planning and assistance, the WIPAs, is because then we will we also clarified in the waivers that when there is a gap, when people aren't eligible for WIPA services, they won't need to be referred to a WIPA. And so we're going to create a policy about what those eligibility criteria are and the people that do not need to be referred to a WIPA and can just get their benefits counseling straight through the waivers. All right, and then moving to life sharing. And once again, I'm so excited. I heard you all are going to have a presentation on life sharing, which is fantastic because people who receive the service, they have really high praise for the service and their outcomes. And so people who receive this service tend to really, really love this service. So I'm just going to give a very, very, once again, as you heard, it can be a whole presentation in and of itself. So I will give just a very high level of what life sharing is and then go over some of the changes. So life sharing is, and also as Lauren had spoken about, one of 3 of the residential service options available through the Office of Developmental Programs. Life sharing is provided in one of the following. It's either a home owned, rented, or leased by a person who will share their home and everyday life experiences with an individual enrolled with the Office of Developmental Programs and provides needed assistance. And so sometimes we call these host families or life sharers, life sharing families. This includes relatives. So they're just people in the community like you or I, really anybody who they want to share their home and their life experience. And it is also provided in a home owned, rented, or leased by an individual enrolled with the Office of Developmental Programs, where a person or persons move into their home and share the everyday lives and experiences and provides needed assistance. So yeah, so it can be the individual can own the home and then like have a person come in. So it's not in our residential habilitation model, right? It's more like staff come in for a shift. That's not really life sharing. Really, it's more, you are sharing your home and your life with really the core family, for lack of a better term, but core people that live in the house with you. All right, so some of the changes that we have made are to the rates for life sharing. So many people who share their homes and life experiences, those life sharers or host families, whatever term makes the most sense to you, they have other jobs and responsibilities in addition to life sharing. So ODP is making changes to our rates to support this. So this goes into effect next week. I can't believe it. So effective October 1st, we will be implementing life sharing with day and life sharing without day rates. And those will be available when the individuals who receive the services need 30 hours or more of support each week. So those procedure codes for life sharing aren't going to change. The current procedure codes for people who need 30 hours or more of support, they're W8593 and W8595, those won't change. However, there is a modifier that will need to be added to the individual support plan. That's modifier HI for life sharing without day. So you might be like, well, what is the difference between life sharing with and without day? Life sharing with day is any day in which an individual receives 5 or more hours of services other than life sharing, or they receive 5 or more hours of unpaid support that is not included in the life sharing service. So they might be out with their friends or family for the day, taking a trip, doing something, going to lunch and shopping and all of those kinds of things, just having a visit. So that would be included. Or an individual who is independent in the home or community for 5 or more hours and does not receive direct services from the life sharing host home. So all of those would be considered life sharing with day. So you can see that they're getting 5 or more hours of service other than, or service, they have, 5 or more hours where the life sharing service each day is not really providing the service and support. Life sharing without day then is kind of the opposite. It's any day in which an individual receives less than 5 hours of services other than life sharing. So let's just say a person is employed and they get supported employment for a couple of hours, 2 or 3 hours to help them at their job, right? That could be life sharing without day. An individual receives less than 5 hours of unpaid support that is not included. So once again, if they're spending, they're out with their family or friends for a smaller amount of time during the day, less than 5 hours, or the individual is independent in the home or community for less than 5 hours. So you can see that 5 hours is the threshold between with and without day. And there are different rates for these depending on whether they're with or without day. Okay, and then family medical support assistance. Now I had to go back and look and let me check my notes. So family medical support was added in June of 2022 when we added children under age 22 with a developmental disability due to a medically complex condition to the people who are eligible for the consolidated community living and person family directed support waivers. So the family medical support assistance assists with the management of services in the person's private home related to the medical needs of the participant with a needs group 3 or higher who use medically necessary technology and require nursing. So, and you'll see as we go through this, why we have these kind of requirements of the person for this service is these people who meet these criteria, they tend to have a lot of different professionals involved in their life, like a lot of different medical professionals and specialists and appointments. And it can just be incredibly daunting for the participant and or their family to keep track of all of how everything interacts, making appointments, what insurance covers, who's going to be here providing what type of special service on what day. It's a lot. So we developed this service specifically to help with that. It includes both, and both pieces have to be there. A provider can't just provide one or the other. They have to provide both. So they have to provide a family support assistance and nursing oversight. And I just want to point out that this service does not involve direct care. So that these professionals are not doing the medical care. These people are not helping people learn skill, perform activities of daily living. This is more kind of like at an administrative level, for lack of a better term. And it's not available to participants who receive life sharing supported living or residential habilitation as a separate and discrete service. We would expect the life sharing provider, supported living provider, or residential habilitation services provider to have people who can do this for the person. So the family support assistant, that that one piece of it. They provide assistance with scheduling and communication between and among unpaid supports and paid services, such as skilled nursing, home health, medical services, and behavioral health services in the person's home. So, and some of these, there's a very long list. I just pulled out a couple of kind of activities just to give an example. So they can help the individual and their family understand, or they will understand the concerns of the individual and family about medical providers or services, and they can assist with mitigating those concerns when possible. They can assist the individual and family with the discharge process from a hospital or clinic or nursing home. They can assist with communicating with insurance providers to, help the individual and family understand what's covered and to help them get needed medical services. The nursing oversight, so that's completed by a licensed nurse, and the activities are within the scope of our states of Pennsylvania's Nurse Practice Act. And it includes the assessment of the individual's medical condition, completion of a health risk screening tool, clinical review in accordance with our protocols, identifying training needs related to the individual's medically complex condition and providing training to the individual, unpaid caregivers, and paid professionals, and training and consultative assistance on implementation of medical aspects of the service plan to the family and team members. So once again, you can see the person, this is not direct provision of nursing. We do have a shift nursing service that would cover that type of thing. This really is more oversight and training. Okay, so there were no changes to the family medical support service recently. I think it's just it is a newer service. Like I said, June of 2022. I did look to see if anybody was authorized for the service or utilizing the service, and I didn't see that anybody is at this time. So this is still something that I think we're working on to to educate people about its availability, and probably still trying to find providers to render the service. All right, and then community participation support. So once again, I'll give, I'm trying to watch my time, a real quick overview of what the service is. It provides opportunities and support for community inclusion and building interest in and developing skills and potential for competitive integrated employment. It should result in active, valued participation in a broad range of integrated activities that build on the individual's interests, preferences, gifts, and strengths while reflecting their desired outcomes related to employment and community involvement. And once again, it ties back to our everyday lives recommendation to increase community participation. So community participation support can be provided in community locations, just everyday locations where anyone is out and about. Community hubs, which are kind of a special, it's a location that anybody in the community can use, but it's usually connected to a specific building, and it's where people receiving the service would gather before they go out to other community activities during the day. Adult training facilities, and these are licensed facilities. The remaining three are all licensed facilities. So they're adult training facilities, older adult daily living centers, and vocational facilities. So one of the, it looks like a new change in that will take effect in January, but this is very similar to the assessments that have already been required for licensing of adult training facilities and vocational facilities. And we have had this requirement in the service definition before now. We just moved it and reworded it a little bit just to help it flow a little bit better with the rest of the information. So providers must complete and update an analysis of the participant in relation to the following at least annually. So their strongest interests and personal preferences for community activities, their skills, strengths, and other contributions likely to be valuable to employers or the community, and conditions necessary for successful community inclusion and or competitive integrated employment. And this is also not new. for the waivers coming up in January. This the Office of Developmental Programs, there was a variance process for individuals who were going to spend less than 25% of their time in community locations, meaning the vast majority of their time would be spent in a licensed facility, which the Centers for Medicare and Medicaid Services kind of view as this segregated type of setting. And so with COVID and the pandemic, we kind of rethought about, first of all, we suspended that variance requirement. And then we started, as the suspensions went on, we thought about how best to achieve the outcomes that the service is really intended to support. And we came up with this. So variances are no longer required when an individual is going to spend less than 25% of their time in community settings. Now, providers with service locations where more than 10% of individuals are spending less than 25% of their time in community settings on average are required to describe a list of things in their quality management plan and the action plan that goes along with it. And once again, this is not an all-inclusive list. But some of those things that need to be in that quality plan, because we are looking for the provider to increase their community time. When this happens, is the number or percent of individuals not receiving at least 25% of their services in community settings, the number of individuals who want to increase the amount of time they spend in the community, and then of those people who want to increase their time, what action steps the provider would implement to help them increase the amount of time that they want to spend in their community. And like I said, there's a list of requirements. All right, so okay, I think maybe time-wise we're okay. I see there are some questions. Let me stop sharing. And
thank you, Julie. And while Maria is going to give you the questions, I am going to try and find that flyer that you noted about the life sharing program that Mary Hartley mentioned earlier. So I'll let Maria feed you the questions and I'll share the screen about that upcoming life sharing program. Thank you.
Sure.
Okay, a couple of things. Someone asked about where can you locate a family support assistance?
Well, that's what, like I said, I was looking up how many people were actually utilizing the service, and I didn't just last year with the year that ended on June 30th, and I didn't see any. So I'm not sure. I need to do more research as to whether we have services, and I don't know if Lauren knows off the top of her head I'm not trying to put you on the spot, Lauren.
No, you're good, Julie. Yeah.
If
all
we have
good.
any providers.
I was actually doing the same thing. I was trying to look and see if we currently have providers that are qualified. And my search didn't yield anything, but that doesn't mean that I looked in all of the available places. And so we can get that answer for you. And like Julie said, because this is still a relatively new service, this is something that is not uncommon that we experience when we introduce a new service, that it takes, a year or two for providers to sort of figure it out, learn about it, and determine if they would meet the qualification requirements to be able to provide it. So, definitely a good takeaway from today's session is for us to look and see, how many qualified providers do we have, and do some additional outreach and training on the topic.
Okay, and then it says for the family medical support, is it available for under 21? And would the child family need a waiver to get that service? If so, which waiver would pay for family medical support?
Thank you for the question, because this is one that I wanted to point out. So yes, it is available for youth that are under 21 that are enrolled in the Consolidated Community Living or Person Family Directed Support Waivers, but it's not limited to youth. It's also available to adults. So I just wanted to say that service is available to anyone in the Consolidated Community Living and Person Family Directed Support Waivers who meet those criteria that I had on the screen. Needs group 3, they need a nurse and technology. So any age. The waivers, it's definitely covered. that was part of your question. So counties also have what we call base funds that are outside of the waivers. And it's a limited amount of money. So I want to I want to point that out. And so counties can use those services when somebody's not when somebody is eligible for the Office of Developmental Programs services, but maybe they're not enrolled in a waiver, or they might be in a capped waiver and they need something above and beyond. So a county could use base funds to provide the service, but once again, there's a lot of need. The funds are limited, and so it's possible. It's possible.
Okay. And the question is, we've developed a wonderful circle of friends, support for our son going forward. When we are no longer able to organize this support, is there a way a consolidated waiver residential provider could support this concept under community participation?
Well, honestly, I mean, when I look at that, I think a residential provider could support that under the residential service. I can't think of a reason why they would need to use a separate service when it really and truly they could do that under the residential service itself.
Yeah, Julie, I had the same thought. And so the other thing too I can recommend is sending this over to the administrative entity and even the regional office to kind of determine what's kind of going on, right? Like, what is the sort of service that's being provided through the circle of friends, and certainly, just have that evaluated in terms of would that be something, right? Like it does sort of lean more towards that residential service that is fully responsible for, all things related to, that person's life. But definitely, send that over if you have questions in terms of what that could look like as a paid support.
And I think the person who asked the question clarifies that their son lives in their own home near us with 24/7 staffing, and the provider leases the house from us. Our intent is to enable our son to live in the community where he grew up and be surrounded by friends who want to be part of his life. So I think that's kind of clarifying or, adding to the concern. So, okay. The question is the community CPS analysis, annual analysis, only for those people in the service location who spend less than 25% of their time? Or is the annual analysis required for all people receiving CPS supports?
Great question, because I went over two things fairly quickly. So the annual analysis is for everyone because it really gets at what the service is providing and how it can help each individual best achieve those outcomes. The quality management plan is only for people who are receiving less than 25% of their time. And that's for, it's not per individual, it's for the whole service location. So like if it's a facility, it's for everybody who receives services in that facility and kind of what their plan is at a higher level. The annual evaluation is individual specific. So I hope that also kind of helps you understand the difference between the two. Annual evaluation, person specific. That quality management plan is for kind of the facility and everyone in it as a whole to like kind of look at what the provider is doing to support, because there's a lot of people not getting a lot of service in the community. So they need to kind of look at what the provider is doing as a whole, and where they might be able to make improvements.
And again, as a follow-up, does ODP have any CPS annual evaluation templates to peruse?
We do not.
Okay. All right, and then someone just to confirm, still working on finding agencies for family medical support, correct?
That is correct. And if we also, just to point out really quickly, we have a services and supports directory where you can find providers of certain services, and we can give you those links later. And if we do find that there are some providers that are enrolled, we can provide that information as well.
Thank you. Okay.
Right. I'll turn it over to Joe.
Okay, let me see if I can get this to share my screen. Can anybody see that?
Yes, yes, we can.
Okay, so this presentation or portion of the presentation is going to be an overview of the new STAT Waiver Service. I believe it was approved by CMS in this past November, and it went into effect in March. So I'll just start by saying, planning for STAT began before I started in my current role. But based on my experience and years I served at Polk State Center, I understand why a service like we're going to talk about today is very important. Many individuals with intellectual disabilities and autism or IDA need to go to the ER for care. And this can be a combination of things such as high risk, multiple comorbidities, lack of access to medical care otherwise, regulatory or policy requirements, and just a primary doctor lacks immediate availability for the individual. So while it's important, very important to get care to ER when needed and when necessary to go. However, we know individuals with IDA going to the ER can be more complicated, not only to the individuals themselves, but family members and caregivers as well. Some of the common issues can be, for individuals, it could be a frightening experience to go to the ER. Lots of sounds and, lights and things of that nature. It can also pose unnecessary exposure to infection, with COVID and all of the respiratory illnesses that float around so much. Can be a disruption of routine. Medication times can be missed, and sometimes the transportation there can be traumatic. For staff and caregivers, it's increased stress on a job and at home, with staffing shortages. It can be difficult to find people for overtime, increased overtime, sleep deprivation, and exposure to infection as well. So STAT, or the Specialty Telehealth and Assessment Team, what it is a 24/7 telehealth service that provides what we call right-on-time health assessments. The service is consultative and provides disability-specific advice of when to best seek additional or in-person medical treatment for the participants. So this is a service that can occur in the participants' private home or residential home to help assess their need for medical attention. And as a part of this would include availability of support and consultation both paid and unpaid caregivers to build their capacity to better understand the best approaches for supporting the participant depending on their symptom presentation. It's written into the service definition that this is not intended to duplicate any service that is available through the state's plan. It's unique and otherwise unavailable through any other service. And importantly, the service is not intended to replace in-person exams. The goal is not to prevent people from going to the emergency room or seeing a physician in person when needed. It's a support that can help to alleviate the burden of all those things we discussed in the prior slides when it isn't absolutely necessary for the individual to be seen in person. This service is billed as provided as a monthly service and billed in monthly units. So one unit equals 1 month, and that is $55 per unit. And then that includes unlimited calls to the service. There's no cap on how many times you can call in a month. And it's available for all individuals that are involved in an IDA waiver. So person, family directed support, community living, and the consolidated waivers are all eligible for this service. It's available for all ages and living situations as long as they're enrolled in one of these waivers. In order to access this service, STAT must be added to the ISP via critical revision or at the time of the annual ISP, which it can be added at any time. So it must be authorized by the administrative entity prior to the service being used. STAT costs will be included in the annual limits for PFTS and community living waivers. And that's a question that's come up quite a bit, whether it was within and without the yearly waiver limits, and it's not, so it is included in the annual limits. So we've already sent out guidance to AEs and SEOs to how to enroll individuals in this service. A few more things about STAT that make it unique and why it is a service that we think will be really beneficial. ODP made very high standards for providers to become qualified to provide this service. The goal is truly specialized care. So physicians that should provide this service must have access and be familiar with the clinical guidelines for the provision of healthcare to individuals with intellectual and developmental disabilities. But it isn't just that, it's something that telehealth service that anybody can provide really requires expertise. Clinical guidelines are based on evidence-based practice and recommendations. All staff who will render this service must have completed specialized training curriculum on how to provide medical assessment and treatment interventions and recommendations regarding the statistical healthcare needs of individuals with intellectual disabilities, developmental disabilities, or autism. And finally, the service must be provided overseen by physicians who are licensed to practice medicine in the Commonwealth of Pennsylvania or have an appropriate reciprocity, meaning they're permitted to serve and then they must be board certified. With the American Board of Medical Specialties, and any functions will be overseen by physicians who meet the above qualifications. Must be provided by a registered nurse, certified registered nurse practitioner, or physician's assistant, all acting within the scope of practice. We do have one provider of this service, one qualified provider of this service currently, and their name is Station MD. And they became qualified at the beginning of March to provide this support. So STAT, it's like I said, an approved waiver service. The service can be added to each ISP, and individuals and agencies will work with their support coordinator to add the STAT service. And it provides 24/7 access to a physician 365 days a year, who triage and evaluate medical conditions as needed. These physicians are specialized with extensive education and experience with the IDA population. If the patient requires higher level of care after physician assessment, they are able to call the ER and give them a warm handoff or other provider like a primary care physician. They also have an aftercare program which nursing follows up to discuss test results and complete clinical check-ins. Technical ability to interface with the patient's medical records if available, and they do that during their onboarding process. They can get consent signed and are able to access some of these medical records. And they have a technical assistant that facilitates every encounter. So how can it help? like I said, it provides immediate access to doctors. All the feedback that I've got from people that are currently using the service, the calls are the wait times are very short. They're very easily accessed and very responsive. So you can get a hold of them anytime, anywhere, 24/7, 24 hours a day, 7 days a week. And they have extensive training and experience working with individuals with IDA. They understand the needs of this population, understands the challenges of group homes, DSPs and nurses, and understand the challenges of families caring for people with IDA. So why is the service important? Again, the doctors are very highly trained in this area. You can avoid unnecessary ER visits and remain in the community, and results in improved quality of life. Spending time with your friends, working, listening to music, it empowers people to thrive in a community by accessing care when they want and need it, from where they're most comfortable. Sorry. Taking control of healthcare needs is a valuable tool for person-centered care. So, like I said, you can call STAT at any time. For questions as simple as I gave the wrong medication at the wrong time. What do I do now? I've run out of my seizure medications. What can I do? I have a cough. Could this be serious? My blood pressure is high. What do I do now? Or even more potentially serious questions. I fell. Do I need to go to the ER? I keep vomiting. Is this an emergency? Should I worry about my fever? I have an odd pain. Is it serious? So the step-by-step process is you call in to the STAT line. You'll get the receptionist, and they will collect patient information, including birthday, current medications, and vitals. And this requires only basic medical equipment, stethoscope, blood pressure cuff. Then you get the technical assistant help you complete the patient check-in from your smart device. So like an iPad, an Android tablet, iPhone, any of those devices will work for the service. And then they connect you with your staff clinician. So who benefits from this service? People with IDA provides immediate access to doctors that understand IDA, reduces time and energy spent addressing health needs, improves quality of life with better health outcomes sooner, and maintain wellness longer. It empowers individuals to thrive in their community and spend more time on activities they enjoy. For caregivers and support providers, gives them immediate access to doctors who can give guidance on any health concern, reduces trips to the ER, urgent care, offers peace of mind, and alleviates stress, and prevents caregiver burnout and staff shortages and turnover. So for sports coordinators, it expands options for people who need more IDA specialized healthcare, reduces critical incident reports, and makes caseloads more manageable, and offers choice and person-centered services to people being supported. And we also have a brochure I can drop in the chat. Any questions?
See any questions just yet?
Not necessarily a question. I did see, I responded to this in the chat, but there was one participant who said that STAT is a concept in particular that sounds like it could really be life-changing for her son and for her family. And we couldn't agree more, honestly. It really is just one of the services that makes a lot of sense from a lot of perspectives, right? Like Joe described, it's not, no one likes being in the emergency department, right? It's not a fun experience. We appreciate and love the folks that are there providing that service, but if we don't need to be there, many of us probably don't want to be there. It's not comfortable. And like Joe talked about, highly like overstimulating, noisy, that all that stuff. So STAT really is just one of the services that makes total sense, and we're so happy to be able to provide it and give anybody, right? Anybody is eligible for this service. And so the relief to family members, right? Having someone that you can call and ask questions and say, do I really need to go to the ED or can this wait till tomorrow kind of thing. Same thing for DSPs, right? When we talk about, their experience and their job satisfaction, they're, having that sort of resource to call for backup, I think is really a game changer for them.
Well, Lauren, Julie, and Joe, thank you guys so much. What a fantastic presentation. So much amazing information. This is so relevant and so important to so many of the families that we serve. So thank you again for your time.
Yeah, thanks for having us.